Okay, so I am going to talk um, about swap programs, and particularly as it relates to my position as the president of the Transplantation Society and views that we have regarding the paired donation programs that are developing. So, just because I'm the first speaker, I'll talk a little bit in concept about what swaps are. Um, if you look in the dictionary, swap means to exchange one thing for another. But as it relates to transplantation, swap is also an exchange program. It is an approach to overcome biological incompatibilities in living donor transplantation, where two or more incompatible donor recipient pairs exchange the allografts or the donated organs from their intended recipients to another recipient, therefore benefiting both or multiple couples and providing more appropriate and compatible allografts. So the timeline of paired kidney exchange goes back many years. Felix Rappaport, who was a transplant surgeon in New York, first came up with the concept of paired exchange in 1986. And this then was translated first in Korea, where kidney swaps were done, followed by individual programs in Europe and the United States and in India. Um, the first systematic approach to dealing with swaps really began in Ohio. And I was very honored to have been a member of the Ohio State Consortium, where Michael Reese from the University of Toledo worked with the Ohio State transplant programs in developing a concept of a systematic swap program or exchange program based on incompatibilities, as I mentioned before. Shortly after, the National Kidney Registry in New York was formed, and then this extended globally into Spain, Canada, Australia, Portugal, and Europe, and now there is a network within Europe. There are some other modifications of the SWAP program, which I'll talk about a little bit, including the concept of vouchers and extension into other organs. So what is a paired kidney exchange? This is given to me by Michael Reese, who just walked in the door. And so this is a concept where blood type incompatibility, in this case a donor into a recipient, would not be considered compatible. And then you have another couple. It could be ABO incompatibility, or in this case, an HLA incompatibility. So here the recipient has an antibody to the donor, and maybe they're mismatched in blood type, maybe they're not. But when you have these two couples now, where you have potential match between the two donors and their corresponding opposite recipients, you have ability then to cross these barriers and therefore able to do, in this case, two transplants where otherwise you would have not done any. Now, this kind of swap concept has evolved, not just from a simple 2x2 to multiple, you can be 3 or more, pooled exchanges, in which case all of the donors and all of the recipients end up matching in one way or the other. Or what has become very extended and become a very interesting way to monitor the impact of donation, of paired donation, is the altruistic initiation of a donor chain. And here you see an altruistic donor who is willing to donate into the system, and this then leads to the initiation of a chain. And the first, really, which I think is pretty impressive, was published in the New England Journal in 2009, and this was chain of 10 initiated by an OBLA-type altruistic donor. Mike Reese was the primary. You can see this included transplant programs from a number of different centers: Ohio State, North Carolina, and Johns Hopkins. So over time, this is really the impact of paired kidney donation in terms of what I showed you, combinations, have accounted for about 20%. About 10 years ago, it was 10%, now 20% of living donor kidneys. And if you include the altruistic donor who initiates these chains, you can see the overall impact is that the kidney swap programs contribute almost 25% of all the living donor kidneys in the United States. There are a number of programs. The Alliance for Paired Donation, which is the one I mentioned that Mike Reese started when in Ohio. It continues to be in Ohio, but has evolved from the OSOTC model, including the New York program I mentioned, the National Kidney Registry, and UNOS having a program which I think I understand is not very functional. But each of these programs have slightly different configuration, and they come up with their matching in different ways. This is one that was published with the Alliance of Paired Donation that Mike runs. But nevertheless, these all have to prioritize some kind of system and to fit what we call the final rule. These are the rules the government has regarding allocation. Includes some emphasis on wait time, HLA matching, degree of sensitization of the recipient, the candidate age, and particularly prioritizing children over adults, trying to minimize the age differential between the donor recipient, and now encompassing distance between donor and recipient to try and minimize cold ischemia time and logistical challenges. And as an example of the Alliance for Paired Donation, point system is shown in this table, and it accounts for all of the things on the left. There also has an evolution now to, instead of using our altruistic donor to initiate these chains, the concept of using an allocated kidney from the deceased donor list to initiate these chains. And this is, again, initiated conceptually by a number of different groups from John Roberts, Alan Leckman, Al Roth, and Michael Reese, but also endorsed by other groups that think that deceased donors, as the initiation of a paired donation chain, is rational and actually potentially increases the utilization of these matched programs. So when we look at these, the opportunities and challenges, the opportunities really to overcome incompatibilities in a number of different ways, not just ABO incompatibility and HLA sensitization, but as we talk about livers, for example, size differential, things like that, it does make more transplants occur, and because we're formulating matching to overcome these barriers, it does improve outcomes. The challenges, there are a number of them, and talking to Michael Reese, he's encountered them all throughout the world. Many are similar challenges, but conceptually, the cost, waiting time, educational barriers, and ethical considerations are all potential challenges. So I mentioned this already, but one of the things that also is the competition between different programs in the these paired exchange registries also reduces the potential donor size, and therefore minimizes or reduces the potential for optimizing the matching algorithms. And so the larger the programs, the larger the donation area, the better chances of finding the optimal matching. There are other issues regarding legislative and legal barriers, particularly when there are rules that prevent non-directed or unrelated transplantation. Some ethical concerns. I think many of them have been ironed out in some fashion, but I'll talk about those at the end. And particularly when we're talking about liver paired donation programs, the partial hepatectomies, which encompass a very high level of technical challenges and potentially having some negative impact in terms of ending chains in the last scenario that I showed you in terms of the chain concept. Regarding the Transplantation Society, most of our policies, in fact all of our policies, are all based on foundational principles. And these have been outlined in a number of different manuscripts and documents. The Vancouver Forum on Living Donation outlines the optimal care and ethical considerations, informed consent, and management of living donors across the different organs. WHO guiding principles regarding transplantation, access to transplantation, and also living donor utilization. The Madrid Resolution, World Health Assembly, and the Declaration of Istanbul, which, as you'll see, will come back in some form in terms of consideration. The Declaration of Istanbul was first published in 2008. It was revised in 2018, and now managed by the Declaration of Istanbul Custodial Group, which looks at changes in policy, in practices and policies, and tries to update the Declaration of Istanbul to fit modern issues. WHO Task Force, and this most recently a Santander statement, which was an outcome from a Santander symposium that was held jointly with the ONT in Spain in 2023. The publications from that have been published, and I would just show you the emphasis in some of the issues relating to living donation, education, and outreach, which I think we've all heard about through the conference, risk assessment, monitoring, and then as it relates to global paired donor exchange, the Santander Symposia supports the concept of global paired donor exchange to increase access across socioeconomic groups and through geography to maximize matching, ensure ethical protections during those both donor recipients who are participating, and standardizing donor policies and best practices. So this is the two tables from the publication, and I would just point out table 2 emphasizing educational things to inform the patients, the donors and recipients about what paired exchange is, participating in it, what the benefits and negativities and some of the barriers are. And then the work group that related to safe expansion of using living donors in more globally talks about access to kidney pair donation programs to be expanded globally, and then how these programs should be structured and potentially collaborate to enhance the distribution of matching, ethical protections that must be ensured, and then talking about global kidney exchange in a way where pairs that have similar socioeconomic demographics are able to be transplanted in a broader sharing kind of situation that is regulated and well defined and as standardized. So I would contrast this with another what we call global kidney exchange program, which had been proposed a few years ago, and this one facing a lot more challenge and a little bit more divisive in terms of the ethical components of it, and this is where a financially wealthy situation, couple or country, would sort of adopt a financially less fortunate couple, probably from a low middle income country, to participate in a pair donation program where the funding for the payment for that low middle income couple pair would be assumed by the higher income country global exchange program. This was reviewed by the Declaration of Istanbul Custodial Group as well as the TTS Ethics Committee, and based on the readings from the principles of the Declaration of Istanbul and the guiding principles, the overall proposal was rejected for endorsement by TTS, primarily because of some of the concerns of how it was being perceived, potential conflicts, and the potential for commodification of the donor from the low middle income country, and potential for then it to evolve into more international organ trafficking. In contrast, the adoption of this global exchange program by the Santander Symposia was really more based on country to country kind of collaboration. So in Europe, there have been a number of countries that have adopted transnational kidney exchange programs, and then actual countries you can see in the color on the right where exchange programs using the kidney pair donation have enhanced the number of countries and pools that donors can be matched from. So this is from the Alliance for Paired Kidney Donation, which has, Michael has shown me, really expanded globally. It's probably, unlike the other ones that I showed you, NKR, for example, doesn't have a outreach program. The AKPD has a global outreach with being able to achieve what will be approximately 500 kidney exchanges worldwide in 2025. You can see the breakdown by country. It is it's a global leader in terms of emphasizing kidney exchange and making it work through their software, and has been successful in working with governments, transplant centers, and policymakers within those countries to make this work. An example which I think is quite exciting, for example, that crosses both religious and political and government barriers, was a recent three couple matching where patients in UAE and Israel were able to embark on a three-way kidney exchange successfully using this program. Michael also has said that in India, with increasing interest, I was taken with a lot of interest, having spoken with Vivek Kute over the last few years about his own center's experience with the KDP program and their association with the Alliance for Paired Kidney Donation, and probably having the largest chain outside the United States in terms of the impact on their living donor program. Dr. Kute, I'm sure, will comment on this a little later. Now, paired donation, not just a kidney thing, although certainly kidneys make up the largest percentage of organs in the paired donation concept, but it can also apply to livers. And here, the Korean group in 2009 first published their experience with incompatible blood group transplantation, overcoming ABO incompatibilities, and the adoption of paired donation liver transplantation, however, is, unlike kidney transplantation, fraught with some other significant issues relating risk benefits and logistics, particularly the risk for the living liver donor in terms of mortality is probably about 1 log or 10 times higher than for a living kidney donor. For right and left side graphs, there are also differential risk factors. There are anatomic factors, as well as I mentioned earlier, the technical demand and expertise required to do the hepatectomy limits the ability for these organs to travel very far. And so most of these transplants are done simultaneously rather than in sequence. I talked about unequal paired exchange when it relates to risk factors, and this has an impact on some of the other combinations that I'll talk about. Having said that, living donor paired exchange has occurred. This is from a recent publication from UT San Antonio, where they've transplanted 11 living paired exchanges with resulting in 23 living donor liver transplants. And then, which I think is really amazing, was work recently published from Turkey, where a number of 2, 3, 4, 5, and 6-way liver exchanges have been done. The challenge here is that every single one of these transplants were done within the 24-hour period. So you can imagine doing a paired liver donor exchange program where you had 6 donors and 6 recipients all being done within 24 hours. So just an example of how this works, this is a 5-way system. You can see they're matched for ABO incompatibility, and they're matched also for size differential, and this is just an example of how a 5-way swap would be. Now, variations on these liver and kidney also talk about trans-organ paired exchange. So I donate as a donor, I intended to give a kidney to my brother, but for some reason that doesn't work, so I'll donate my liver to another recipient who needs a liver, and in turn his donor, who would have normally given him a liver, would now donate a kidney to my brother. So this is a concept which has really only been published at least one time by the University of California, San Francisco. And again, the emphasis here ethically is that the donors have different risk for the donation process, and it's not necessarily an equal swap. But having said that, this has not been really studied in any great detail. Another one, which I think is somewhat connected to the paired donation, is this concept of vouchers. And I would just mention one of the programs in the United States, the National Kidney Registry, does allow for patients per people to donate a kidney as an altruistic donor into the chain, and then receive a voucher for that person either to give a kidney to somebody within their family or a designated person later on, or to keep that voucher for himself or herself if in the event that person needed a kidney transplant in the future. You can imagine the voucher system now begins to walk on the barrier between ethical and non-ethical, primarily because the concept is now you have a piece of paper that says your kidney was a commodity and it can be traded. And so, having said that, there are two views on this issue, but since the voucher system has not really gone into a full effect, and we don't really know the implications of that. So just to conclude, paired exchange swaps, the Transplantation Society supports and endorses paired donation, but only when the donor recipients are fully informed on the risk benefits and the process of participating in the program. There should be no net or little tangible benefits accrued to one party over the other party. In other words, risk and benefit should be shared between the two, and the overall risks should be relatively neutral between the donors on both sides. But having said that, this is a new field. I think we'll continue to see more challenges, more situations that require some ethical considerations. But in whole, the TTS feels this fulfills one of the objectives of the WHO in terms of providing more life-saving transplants and potentially has a global impact. Thank you.